Hi, I'm Vinod Thourani, and I'm the Marcus Chief of Cardiovascular Surgery at the Marcus Heart and Vascular Center at Piedmont Heart Institute in Atlanta, Georgia. And my topic today is TAVR in the low risk era, the impact in the United States and important future considerations. These are my disclosures. I also want to disclose that using COVID policies for our hospital, I'm here alone in our studio, recording by myself, maskless, so that we can have a nice environment, COVID-free. I do want to just give you a little bit aspect of our own hospital system. We are one hospital out of 15 in our network at Piedmont Healthcare and the Piedmont Heart Institute. And we're actually in the acquisition of 3 more, so it could be up to 18 hospitals in the state of Georgia. And you can see our picture of our new hospital, the glass tower, in addition to our continuing hospital that we have. And here, this was by the benefactor of Bernie Marcus, who has been very kind in helping us support this hospital. And you can see a very new state-of-the-art Marcus Heart and Vascular Center that we have, and we wish for you to join us in Atlanta sometime. Let's really talk about the agenda today. One is the state of TAVR after low risk approval in the United States, and I'm so excited that in Japan you're going to be heading towards low risk approval also. We'll talk just a little bit about the ACC/AHA guidelines and the valvular heart disease. I know you have your own guidelines in Japan, but I'll just kind of update you a little bit about ours. And then what I think is very important, and I've been a huge advocate for, is a heart team in the United States. And lastly, some of the future considerations in low-risk patients. The outcomes from the partner trials have unlocked really TAVI for patients with severe aortic stenosis. I remember my first access to this in 2006, 2007, and we started with a partner 1B study, which led to a New England Journal Medicine presentation. As you can see here, then this was followed by the high-risk patients that were operable. So the first 1B was inoperative patients against medical therapy, and then 1A was against surgery patients, a randomized trial, really a unbelievable pathway into really studying very eloquently the management of severe aortic stenosis. Next was intermediate risk patients, which was also published in the New England Journal of Medicine, and then most recently the Partner 3 study in low risk patients, also from the New England Journal of Medicine. And really what this has done is it has moved the bar from aortic stenosis from high risk to intermediate risk and low risk, all getting approval, all based on science in randomized trials. And I'm very proud to have been a part of these trials. And overall, we've seen improved clinical outcomes in transcatheter therapy. You can see the 30-day all-cause mortality for SAPIEN 3 at least, unbelievable, 0.4% at 30 days, and stroke rate of 0%, disabling stroke rate of 0%. And we've made a lot of progress going from high risk all the way down to low risk. And if you look at just a 30-day, 1-year comparison for this, you can see that all-cause mortality was 0.4% for a transcatheter valve, and at 1 year, 1.0%. You can see the stroke rate of 0.6 to 1.2. I'm just concentrating on the transcatheter component of it, and you'll be realizing this soon as you go into low-risk patients yourself. But what we're really seeing is at 1 year, better than surgery in mortality, stroke, rehospitalization, and bleeding if you look at them individually on top of the combined endpoint, but also individually. I'm going to give you some data that has been unpublished, quite honestly, and is just for Japan for you to see. I've just recently received these slides. One of my jobs really is the co-chair of the U.S. Transcatheter Valve Therapies TVT database, and so this is some data that I'm going to show you hot off the press from the United States. We have combined data through 2019 of the STS and TVT databases, and what we're able to see is that over the years, really from 2012 all the way to 2019, there is a substantial increase in TAVR volume. You can see about 78,000 patients in 2019, and I'll give you full 2020 data. But when we merge these two together, we just have up to 2019. You can see that the SAVR volume has gone down. And in 2019, 55,000 overall AVR procedures were done. When you look at just isolated SAVR procedures over the last 5 years, it's gone from 30,000, now it's down to 20,000. And so you can see that there has been a decreasing surgical volume across the board for patients in the United States. Now, the data that I'll present to you now is 2020 data. It's complete 2020 data, and this is just beautiful data for you to see. You can see low-risk patients now, the average age is 75 for patients undergoing TAVR. You can see intermediate and high risk are roughly in the low 80s. You can see here, this is the median STS score for patients undergoing TAVR. Here you can see 2.3% in the low-risk patients is the median STS score, 4% for the intermediate risk patients, and 6% in the high-risk patients. There's a difference between STS scores and the actual heart team reason for having the procedure. And you can see the fastest rise proportionally has been low-risk patients. It is now almost one-third of all patients undergoing TAVR in the United States. There has been a decrease, obviously, in the extreme risk and high risk as there's been a comparable increase in the low-risk patients. So the way I think about this is a third, a third, and a third. About a third of the patients now in the United States are low risk by the heart team who undergo transcatheter valve therapy. This has been changed over time. My own personal practice is that all of our patients, except the carotids or the subclavians, are done in the hybrid room. All of our patients have been done in the cath lab. And you can see there's been a change. So you can see about 18% of patients now are in a purely cath lab, 30% are in the cath lab that are hybrid, and about 52% are in the hybrid OR. So roughly split 50-50 when it comes to cath lab versus hybrid ORs. You can see there's been a decrease in the hybrid ORs. I think this is also in relation to the decrease in alternative access being utilized. We currently have 2 cath labs that I use every Tuesday and Wednesday for our cath lab or for our TAVR procedures. You can see that the femoral access has dramatically changed. You can see it's gone from 70% in 2014, and now in 2020 it was 96% have been done transfemorally. When we have some data that looks at the different alternative access, you can see carotid has now risen to one of the largest for alternative access. You can see that that's for the full year of 2019, it was the most common alternative access. I first did my first transcarotid in 2012, and now you can see that it's really caught on in the United States. The median length of stay has changed for those patients who are low to intermediate risk. The median length of stay is 1 day, and it's 2 days for high-risk patients. The overall length of stay in days, as you can see, has changed a little bit over time. If you look at it in these column graphs, you can see it's gone from 6 to 2 for those patients who are considered high risk. So I'm very proud to see there's been a good change in the length of stay for these patients. Pacemakers peaked after the introduction of self-expanding valves. It has now come down for both for all patients. You can see that the 30-day pacemaker rate is roughly about 10%. When you look at stroke rates, they have slightly come down, not as much as we would think. This is in a hospital in blue, 30 days in red, and 1 year CMS linked is in green. You can see that the 30-day stroke rate is now about 2.1%. Here in Arrow in 2018 was the introduction of the Sentinel procedure in the United States, and has had a slight decrease in stroke rates, at least at 30 days. In the United States, about 13% of patients undergo the Sentinel device in 2020. For TAVR mortality, you can see that blue represents in a hospital, and 2.2 represents the 30 days in 2020. And you can see that we've had a nice decrease in mortality, as also the risk profiling of the patients has decreased. If we just look at the year of 2020, you can see that the overall mortality in a hospital was 1%. It was 2% at 30 days. You can see that in the low-risk patients, it was 0.4%. It did go to 1.6% at 30 days. So really the trends in TAVR since the initial approval in the United States has been quite remarkable. And this just gives you an overall aspect of it. The total volume has increased. The sites performing have increased. The access has switched to transfemoral. You can see that the indication expansion has gone such that low risk has become very dominant. And you can see the outcomes have changed so that there's a better outcomes across the board. So we're very proud of that, I think, in the United States to, one, monitor all of these patients, and then second, watch the trends as the indication has become more liberal, period. So it'll be interesting to see how this continues in Japan. We look forward to partnering with JTVT and also for you to understand what's happening in the United States and whether you'll follow into that pathway also. I just want to mention a little bit about the 2020 ACC/AHA guidelines. I think this is really important. They have used age as a criterion, and maybe there's a different ways to look at that. But what's really important is that once you know that the patient is going to have a tissue valve, a bioprosthetic valve, then really age 65 potentially, they said maybe that's something that goes to surgery. 65 to 80 goes to surgery or TF TAVI, and then greater than 80 goes to TF TAVI for the most part, with a class 1 indication, and SAVR would be a 2A. So this is really the breakdown, I think, for the 2020 guidelines. There's been a lot of controversy on whether age is the right aspect to look at. All of us who take care of a lot of patients know that sometimes a 60-year-old is really not a low-risk patient. That patient could have had a previous liver transplantation or cirrhosis that really takes them into a different pathway. And in some ways, the way I look at it more is what is their life expectancy, more so than actual age. Let's talk about the heart team. I think this is really important. It's been the crux of my career nationally, regionally, nationally, and internationally, trying to advocate for the heart team. I think this is very important. It's no longer just a surgeon and a cardiologist. I think it has a lot of people who are really involved in these patients to give them the best therapy. This is not only just for aortic valve, but we commonly do this for mitral valve and tricuspid valve also. So I believe very wholeheartedly in the heart team. I think this is very, very important. And I think that the role has changed. The role will continue to change. Right now, surgeons are intimately involved and are required for a TAVI procedure in the United States. Hopefully that will continue. I thought I would give you just a glimpse of our own system that we have in the Piedmont Heart Institute. We'll have 15 hospitals. Of those 15, 2 will do TAVR. Of those in the Atlanta hospital, where I'm mainly based, we'll do approximately 500 TAVRs. We have 2 interventional cardiologists and 3 cardiac surgeons. We're in the process of hiring a 3rd interventional cardiologist, so there'll be 3 and 3. In the Athens hospital, we do about approximately 100 TAVRs there a year. We have 2 interventionalists and 2 cardiac surgeons that are part of that team. In the Atlanta hospital, we are we now, because of COVID, have gone to a web-based heart team assessment. And every Thursday from 7:30 to 8:30 a.m. and every Friday from 7:30 to 8:30 a.m. we do a web-based aortic valve call on Thursday, and we do a mitral tricuspid call on Friday. And I'm so proud of our team, because what we're able to do is we have not only interventional cardiologists and cardiac surgeons, but we have imagers. We have our advanced providers, including our nurse practitioners and our physician's assistants. We have our valve coordinators. We have our research team, who really spend a lot of energy going through every single valve patient and trying to decide, is surgery the best pathway, or is transcatheter valve technology the best pathway? So I'm very proud of the maintenance and the continuation of the heart team at the Piedmont Heart Institute, which I think is critical and very well balanced. And I think the most important thing is that it helps the patient. So I will tell you, in 2021, our conversation is not just, let's just have aortic valve surgery. It's whether they have minimally invasive aortic valve or sternotomy, or we have transfemoral, transcarotid, transsubclavian, transapical, transaortic. And as fortunate as a surgeon that we can do all of these with our cardiologist. So I think that this is a very important aspect for us to consider. Future considerations in low-risk patients. I think this is a very important topic, and I would say I spend most of my time giving lectures, when I do give lectures, about this specific topic. What is the lifetime management of aortic stenosis? It starts with the diagnosis, followed by a referral, and then a TAVR versus SAVR decision first comes in. And then the decision is THV versus THV, or do we do an AVR? How do we monitor these patients? And what is the next reintervention? Not only do I count and counsel my patients with my cardiologist, I actually am physically in the room with our cardiologist when we talk to these patients. We talk about the next 20 to 30 years. And so in low-risk patients, the conversation is not about this procedure, but it's about this procedure and the following next two procedures, and I think that's very important. Choices for aortic valve disease can be SAVR, biologic or mechanical valves, TAVR, annular versus supraannular valves, and then medical therapy. Those that have severe medical therapy or severe symptomatic aortic stenosis, we really believe is not a role for medical therapy at this point. We believe TAVR or SAVR are really the right options. It would be I would be remiss in not mentioning mechanical valves. Those patients that are less than 55 to 60, we do consider other alternative bioprosthetic valves for them. This includes mechanical prosthesis or the Ross procedure. However, these patients do require Coumadin for life, and that's something that we're cognizant of. Most of our patients do choose tissue valves, but I do want to mention that this is a topic that we discuss once we have the patients of 55 or less. And as far as surgical valve therapy, I do also want to mention that of what is very important when we talk about the lifetime management of aortic stenosis. This is the valve of my choice, and the reason is that it allows us to have the VFit technology, again, thinking about the next procedure. So this allows a future TAVR and SAVR a little bit better effective orifice area because we're able to open this valve up once we perform that TAVR procedure. So this is a very important aspect for us, and we've changed all of our valves to this when they require surgery. And I think that age is important. Age has made the greatest difference among patients in the low risk. As you can see here, this is a slide from Dr. Brennan in 2012 where age really became important. So here you can look at the green lines. There are three, these are all low risk patients. You can see that if the patient was 65 to 69, if they were 70, 79, or 80, all considered low risk, you can see that their 8-year survival at 62% of these have 8-year survival. So I think this is important for us to understand the age, but I think it's physiologic age, not just sometimes chronological age. Some of the things that are important are the durability and subclinical leaflet thrombosis. These are some of the missing pieces for low-risk TAVR trials. I think this is something that we need to continue to follow and understand this. Patients who have bicuspid valve disease, extensive CAD, aortic aneurysms, or associated MR and TR were excluded in the low-risk trials. So these are low-risk patients that we still need a little bit more data on. And I think the younger patients, those less than 65, I think durability and pacemaker rates are important, and we'll just touch on this a little bit. Lastly is asymptomatic patients. All of the trials were symptomatic patients with severe AS. The early TAVR study sponsored by Edwards Life Sciences is looking into the asymptomatic population currently. And one aspect is that what happens with low-risk patients that have mild PVR? I think there's a lot of technology that's led forward to decreasing that mild PVR rate, especially I think that for me has been better in the Ultra Sapien valve, Sapien 3 valve, which I think has made an improvement from the Sapien 3 valve itself. So I think that there's a lot of aspects that we are still missing in low-risk patients that will lead to a lot of great research in the future. And if you look at this, some of the data for low-risk patient differs. For instance, I don't think that one valve is comparable to a second valve. I think you have to look at the data across the board, and this just gives you the difference in the partner 3 in the Evolute low-risk trials. So when we talk about low risk, I think we have to be careful that we're device specific, not just using the word TAVR in general, but device specific. I think that's important for us to understand. Pacemakers are an issue. I think that we try to minimize that as much as we can. As you can see on the right side of the slide, you can see that if you have a pacemaker versus not having a pacemaker, it does lead to increased mortality. And I think that's important. It also leads to increased rehospitalization for heart failure. So in low-risk patients, this is a consideration for me at the pacemaker rate, and trying to decrease pacemaker rates are unbelievably important to me. The next is bicuspid valves. As patients get older, as you know, there's less bicuspid valves and have more tri-leaflet valves. But I think that this is an important thing for us to continue to understand. This is a prevalence of bicuspid valves in TAVR patients by country. You can see the U.S. has probably one of the lowest rates, where some of the other countries have a higher rate. But I think this is something that we'll need to work very carefully with surgeons and cardiologists together. For instance, here's a patient. As you can see, a lot of calcium in this patient. It's a bicuspid valve. You can see that the calcium not only is there in the leaflets, but it's also going in the annulus into the LVOT. And this is a patient that we most likely would take into a SAVR pathway if they were low risk. I thought I would show you here of those patients who have aneurysms, most likely have surgery, especially if they're 4.5 centimeters. And here you can see a patient of mine that where we have removed the aorta, and we'll plan to do an aortic valve replacement and an ascending aortic replacement. And you can see this type of patient, I think, who is low risk undergoing TAVR may have some potential problems, but I think that's the pathway that we have. Not only that, but here's a patient, you can see that's 67, who had an aorta of 5.0, and this patient ended up having a concomitant surgery with aortic valve replacement and having aortic aneurysm repair. So I think this is where surgeons and the heart team together make very nice decisions. And of course, this patient had a valve replacement. The patient ended up having a 25 Inspiris valve put in, and we're setting this patient up for the next 2 procedures. The patient will have a TAVR and SAVR next, and I think the patient will do great. So I think that bicuspids, people have shied away from bicuspids for TAVR. However, I'll show you some data that I'm very happy with some of the results with the bicuspids in TAVR, and I think that patient selection becomes very important. Those patients who have a calcified raphe probably should not have TAVR. You can see here the all-cause mortality is a little bit higher at 720 days. But I think that those that have no raphe calcification or non-calcified raphe really are patients that will do quite well. Most recently, there's a paper that we presented at EuroPCR between Raj Makar and myself, where we actually looked at the most recent valves, the ultra valve, and this gave us even the best data that we have so far. You can see now that bicuspid and trileaflet are reaching really very similar outcomes in death at 1 year. You can see, in fact, here there's a trend towards bicuspid valves doing better. When you look at stroke, there is no difference now. So we're starting to see, with newer technology and better experience with bicuspids, we're seeing very comparable data between trileaflet and bileaflet, all with TAVR patients. We are able to propensity match over 6,000 patients with this. And if you look at new pacemakers, there was bicuspid was slightly more, but not significantly more. Need for dialysis with a little bit more in the tricuspid valve patients, but there was no major difference, and I think that's really heading into the right direction. And that's not only true for 30 days, but also showing good results at 1 year. This is what I talked about earlier. I think that we're now starting to really make some impact on the mild paravalvular regurgitation. As you can see, moderate severe is almost negligible, but now we're starting to make a dent in the mild. And you can see that SAPIEN 3 being on this column. You can see the ultra almost cut in half the amount of mild paravalvular regurgitation. You can see 24% at 1 year, and now 13% with the ultra valve. So we're making progress with the ultra valve in decreasing mild regurgitation. The mean gradients are right on top of each other, so I'm very happy to say that we're heading in the right direction. One of the other aspects that has become incredibly important in lifelong management is coronary artery disease. It's very common in the TAVR population, even among low-risk patients. And I think that that's really, really important. You can see that the PARTNER 3 study had over 20% of patients, and so that becomes very important on how we deal with these patients long-term. And this has become one of a differentiating factor for me, at least clinically, on what type of prosthesis to use on the TAVR side when I'm dealing with young patients. You can see that the reaccessibility for the ultra was unbelievably easy to do, and so that becomes very important. In fact, predictors for unsuccessful cannulation at our odds ratio of 29 is a self-expanding valves. And so I think we're making a lot of progress in understanding what is best for a patient down the road. And I think that will become even more important. So here you can see this is from University of Padua. Implantation of supraannular valves and narrow SCJ were independent predictors of impaired coronary access post TAV and TAV, and I think this becomes very important for us to understand that. So not only is it just putting a valve in anymore is as important, it's how we deal with the next 1 to 2 operations. And this just gives you a little bit of idea of that it's also not important just looking at the annulus, but also looking at the STJ and the sinus of Valsalva itself and the height of where these coronary arteries are. One of the aspects I also wanted to mention on pacemakers is that there's a 31% increase in mortality in the first year and a 42% increase in rehospitalization. I think that's really important. And this shows you over time in 2021 a TVT project that showed low consistent balloon expandable valves pacemaker rates. You can see there's been a decrease in newer generation self-expanding valves, but there's still over a 10% rate across the board. So when I look at low-risk patients with severe aortic stenosis, there are categories that still require surgery, and there's categories that are expanding for transcatheter valve. If a bicuspid valve has poor TAVR anatomy, that patient should have surgery. Those that are large annulus out of the range of TAVR should have surgery. Those with very small sinus of Valsalva, or those with massive LVOT calcium at risk of root rupture in the low coronaries, all should go towards surgery. Again, remember, we're talking about low-risk patients. For TAVR, those patients that have bicuspid with good TAVR anatomy, I think now in our practice and nationally is starting to head to TAVR. Tricuspid aortic valves are clearly heading towards TAVR. The smaller annulus with an increased risk of a 19 surgical valve. Now, maybe that's different, I think, in the Japanese population where the body's surface areas are much smaller, but generally in the United States, those that get a 19 valve are heading a lot more into the TAVR pathway for better effective orifice areas. And then, of course, large sinus of Valsalva to accommodate aortic valve, I think, is important for that. So when we look at the first decision on AVR, it impacts others. It's not just the age at first AVR, but it's the life expectancy. And if it's 5 years, then I think you have a different type of implant. You're just worrying about one implant. If we think they're going to live more than 15 years, you're thinking of 2 implants. And if they're more than 25 years, you think about 3 implants. I think that's very important. So the decision for today impacts tomorrow's decisions. When I look at all the data for TAVR and SAVR, surgery is better in a couple of categories. They're equal in a couple of categories, and TAVR is better in these categories. I think it's important to understand what these are. In the next 2 conclusion slides, I think that TAVR devices and techniques will continue to improve. There are now a lot of computational simulation for root rupture, thrombus, and coronary occlusion that I use through DASI simulations. Patients always prefer less invasive therapy, and I think we need to understand that, and we need to allow the patients to tell us that. The option for valve-in-valve allows a bailout for valve failure down the road, not only for TAVR and TAVR, but also TAVR for SAVR. TAVR remains superior in early outcomes, and it is non-inferior at 5 years. And there's no doubt in my mind that the paradigm has changed for a TAVR first pathway for trileaflet aortic stenosis and select bileaflet aortic stenosis. Also, the lifetime management has become very important. The tissue valves are preferentially chosen in those over 50, 55 years of age in the United States. Patients are expected to undergo TAV and TAV in their lifetime. The choice of the first TAV impacts the risk of impaired coronary access upon the second TAV placement. I think that's very important. I think the heart team should stay intact and should decide on the scenario for current valve prosthesis and future interventions. Should it be a SAVR followed by a TAVR, followed by a TAVR and TAVR? Should it be a TAVR followed by a SAVR and then a TAVR and a SAVR? Or should it be a TAVR that's followed by a TAVR and TAVR and then a TAVR and TAVR and TAVR? And luckily, I don't have to say that 3 or 4 times in a row. But in those where TAVR is chosen, there should be consideration for the next procedure and for the future need for coronary access. And in my mind, we know that SAPIEN 3 is more easily facilitates future coronary access. It's my pleasure to have given you this talk and look forward to comments. Of course, my email is readily available and happy to answer any questions. Once again, thank you very much, and please stay safe.